First of all, we've all heard this morning repeatedly that we are constantly challenged with emerging and re-emerging infections. And the red dots there signify the emerging infections, and the blue ones or green, depending on your color views, are the re-emerging infections. So it is not an issue in Africa only, it is a global issue because of the factors that Dean Williams mentioned: climate change, population movement, and increasing urbanization. And if you look at this slide carefully, and this is a study that was published in 2014, it clearly shows on the right, the left-hand panel, the increasing infections there globally. Then if you break them down by either whether they are human or animal-specific, you can see that the same trends apply. I mean, they're all increasing. And even break them down more specifically by disease ecology, whether they are fungi, infections, parasites, or viruses. The green column there, you can see that it's clearly, we're faced with increasing infections across the board. So the thing that draws attention most often in the world is the hemorrhagic fevers, and the Ebolas, the Marburgs, and others there. And I throw this slide up to say that it is everybody's problem in Africa. It's not just DRC. Our focus is in DRC now, and our focus has been in the last few years in West Africa, but hemorrhagic fevers and other infections are happening across the continent, which means we have to consider this as a continental threat, not just a regional threat in any specific region. So the Commissioner of Social Affairs mentioned in her introductory remarks about 3 initiatives that our continent is moving forward with: a free trade agreement, free movement of people, and the open skies. These are all big initiatives that this body, the African Union Commission, is driving through. And in less than a few months, when 3 or 4 countries rectify their free trade agreement, it will go into effect, which means goods and people will be moving across the continent more rapidly. A continent of 1.2 billion projected to be 2.5 billion by the year 2050. That has strong public health implications. I mean, in as much as it's potentially going to give us tremendous economic benefit, we should always remember that underneath this lies a strong need for public health systems. So we always said it's probably not a good thing to predict the future. We should prepare today as if the next outbreak will be tomorrow. But when is the next outbreak likely to occur? As a virologist, I think we will be challenged by a virus infection, similar to the pandemic flu that David and Michelle touched on. It could be respiratory, enteric, vector-borne, in that sequence of priorities. Influenza is a topic of interest. So it is very difficult in my view, and I designed this slide purposely to challenge and stimulate a discussion. And I'm saying it's difficult to predict where these outbreaks will occur. Most of the time we are wrong. Okay, in 2009 we were thinking that the outbreak, the H1N1, will occur somewhere else, and it occurs in a different place there. So predicting requires a lot of biological knowledge in addition to sequence and phylogeny, which we are investing on, and I'll come back to that subsequently. It also requires biological knowledge, which is scarce for new viruses. So we are left with one choice if we really need to be prepared. We are left with a choice of putting systems in place for early detection, which includes training, capacities, and resource mobilization. That, to me, is a very simple way to look at preparedness there, rather than think of things that we can predict and do nothing with it. So my remaining comments will be focused on the 3 components there. So public health workforce development. We know that, and for the longest, that everything that David said this morning about the charges that he gave us to do requires a competent workforce development. It is Africa CDC's vision and aspiration that we should aspire to have a workforce development strategy similar to what the US CDC has in terms of the EIS, which is the Epidemic Intelligence Service. We should aspire to have what the European CDC has done in terms of APA program, and I'm very happy that my colleague and friend Andrea Among is here, and Benjamin just came back from European CDC to learn how to develop these partnerships so that we can develop a similar program for the continent. And so the question in Africa is, what kind of program do we need for public health development? Not just the FETPs, but the laboratory programs and information systems there. Another area of focus that we are looking at is how to provide oversight and quality. And I'm happy that last year we started that dialogue with two of the bodies that are driving this on the continent, the AFINET, which is the African Field Epidemiology Training Program, and the AMPNET in North Africa. Dean Williams touched on the need to mobilize schools of public health, and we're doing exactly that. That is one strategy we are using. We are saying we have to tap on all our public health resources in either pre-service training and in-service training. We have just developed a program and launched a scholarship program for a Masters in Public Health with the WITS School of Public Health in South Africa. And these are some candidates that we've pulled from National Public Health Institutes and assigned them to South Africa. And we'll be looking forward to developing a similar program with the School of Public Health in Morocco with Professor Marofi. So the intent here is to say that we can achieve quality education for public health on the continent using our own resources as much as possible. So these are experimental phases that we want to develop, and are seeking for partnerships to expand this kind of programs within the continent, for the continent. Another area of interest in workforce development is a partnership we've developed with the Emory School of Public Health, which we are calling the Africa CDC Institute of Workforce Development, which is geared towards developing public health surveillance, antimicrobial resistance, writing proposals and grants. All of this comes with funding, and very importantly, leadership and management, again geared towards the national schools of national institutes of public health. David Herman touched on this. He said the head of states of Africa in 2015 issued a commitment in this same hall saying we should develop, in partnership with our collaborators, what they call the African Health Voluntary Corps that will be used to respond to diseases. Again, I'll pause and insist on this. As David said, the international health regulations do not say that capacity should be developed elsewhere and then you fly that into country X and do that. It says do national capacities. This is exactly the call to action that the head of state issues there. So what have we done in this space? We are seeking for partnerships, and the partnerships that we are looking for are partnerships that speaks to our vision, and not partnerships that tells us what we want to do. And one of these that I really want to highlight here is the partnership with the Public Health England, where we are doing an inventory of who is doing what in the space of response. We do not want to replace countries, but we want to know where the capacity is. As they say, information is liberating. We want to document that on the continent, so that we can report to the leadership of this house and say, look, this is where the capacity lies, and you can use that, recognizing that the ability to respond should be residing within the member states, not with us. Secondly is we begin to train a cadre of what we call elite responders. Say, well, member states can develop their own capacity, but there might be a need for them to call on us, as we've done in DRC, where we're developing a cadre of rapid responders from 22 countries that are on standby. We continue to develop them in a cohort fashion that can be deployed every moment. In DR Congo, in the spirit of what the head of states issued here in 2015, we have deployed almost 45 responders in the field. And this is not intended to be a presentation on DRC, but just to show you what we can do if we have the resources there. We have 24 epidemiologists out there working to support the DRC government in infection controls, surveillance activities across multiple sites that are infected, mainly in Butombo. We also have, working along WHO, as you can see these two individuals with their jackets here, working with the community, really to look at community death investigations and going into remote areas. Okay, these are things that only Africans can do. There's no way you can bring someone from outside the continent and deploy them into these settings for them to respond. In the area of labs, we've set up at least 6 laboratories and provided about 3,000 cartridges there to support testing for Ebola in several places in DRC there. Again, under the umbrella of the ADVOC, the Voluntary health core that the head of states asked for us to develop, and we are moving forward with that. It's important to state that all of these responders are Congolese. They are people from DRC. So my message here is that if facilitated, Africans can respond, take their responsibilities appropriately and adequately, and address some of these challenges there. Infection control similarly there. NPHI is the second focus here. We are saying, and we spent yesterday, the entire yesterday, discussing, debating that, saying the way to harness our public health systems is to have a house for it. And the house for that public health system should be the National Public Health Institutes. Okay, we strongly advocate for that. We think that is what is going to define our preparedness ability on the continent in a way that we can actually show that the needle has moved from left to right. And this slide just shows you countries that have developed their National Public Health Institutes. The yellow are those that are taking on that journey. But the challenge is that many countries have not yet even started that journey. And this is an area of partnership that we are seeking with most of you, the partners that are here. So National Public Health Institutes, we believe, should do a couple of things. One, they should really invest in surveillance, what we are calling smart surveillance. Yesterday, Robert presented in the pre-session about the need to focus on event-based surveillance, which we are saying, if you couple that to indicator-based surveillance or what we call traditional surveillance, then it can actually begin to be your system for early warning and will detect quickly events quickly and respond to them. We now recognize that we need a comprehensive system that most outbreaks are never detected. So we need to close that gap at Africa CDC and with partners. So what have we done? We've developed a comprehensive event-based surveillance tool. As we speak, some of our staff are actually in Kenya, working with the government of Kenya to implement some of that. We've actually said that these guidelines should be more comprehensive and should be in a way that we should link them out to the integrated-based surveillance that WHO Afro has developed. Another area that we are insisting we should be developed is the need to have next-generation sequencing and whole genomic sequencing. Our Nigerian colleagues, Chikwe and others who are here, will testify the need for such a tool and how instrumental it was in investigating the large Lassa fever outbreak that occurred last year. And these are sequencing that was done in real time. These are not studies, to actually determine the source of infection. And the outcome of this was that, the Lassa fever infections were not coming from human to human transmission, they were coming from animals to humans. And that actually helped define the strategy or redefine the strategy for its control. So that is an area we are moving forward with. And we're very happy that Ninguchi Institute and other institutions like ICREID in Senegal and other institutions in South Africa are working with us to develop a network under Dr. Phillips Onyeboju's leadership. So to move on, we say we need an integrated approach that instead of looking at the silos, the HIVs, the TB programs as a silo, we should be looking at these horizontal aspects, the surveillance systems that are more coordinated, laboratory systems that are more coordinated, new information systems, including the use of social media, and preparedness and response teams that cut across not just for outbreaks, but you would prepare them in peacetime, that we can use them in wartime. And along those lines, I'm really pleased that we have moved forward significantly with respect to establishing what we call the Regional Integrated Surveillance and Lab Network in Central Africa, which is a model which we hope to move forward in West Africa with Stanley and others very, very shortly there. The concept of the RISNet at this call is that we have the assets, the public health assets that we have in the region, but we need to pool them together in order to respond to our needs. So rather than wait for, aim for other resources that will come from outside. So we're really looking forward to prioritizing this and developing the appropriate partnerships to drive this forward. This is just a statute of the RISNet in Central Africa that was approved by the leadership of that region. And as I say, we need to move this forward to other regions as quickly as possible. Lastly, is just to say that we need to also develop capacity to archive our own findings there. Aspiring to publish our needs, public health outcomes and needs in other journals is okay, we should. But we should also be publishing it in our own journal, in our own context. And that's why the Africa CDC has now developed a own journal called the Journal of Public Health in Africa, which we strongly encourage you all to begin to look at in terms of publishing your findings on the continent. So thank you so much, Mr. Chair.